Good evening, everyone, and welcome to today's webinar, Manage Multiple Sclerosis Pain. Your presenter is Laura Bruggink, and my name is Annie Sasson, and I'm your facilitator. We begin all our webinars with an acknowledgement. We acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. Okay, it's my great pleasure to introduce you to Laura now. So Laura is an Australian Physiotherapy Association titled Pain Physiotherapist, that's a mouthful, who is passionate about improving the lives of people who experience chronic pain. As well as her physiotherapy degree, Laura also holds a master's in pain management. So you're a lot of experience tonight, so that's great. Laura works at the Hunter Integrated Pain Service at the John Hunter Hospital in Newcastle, as well as via telehealth for the Tamworth Integrated Pain Service, both of which are multidisciplinary teams consisting of doctors, physiologists, nurses and admin staff. Laura is involved in running group treatment programs as well as individual consultations. And outside of work, Laura enjoys spending time with her young family and attempting to practice what she preaches at the gym. So that's wonderful, Laura. It's great to have you on board. And thanks a lot for presenting for us today. And on this slide here, it's just a slide on informed choice. And now I will hand over to Laura to begin her presentation for you. So bear with me a moment while I click a few buttons. And Laura, you should see a slide come up on your screen.
Yes, I can. And can you now see my screen?
Yes, I certainly can, and I can hear you loud and clear. So over to you.
Okay, thanks so much, Annie. Hi, everyone. Thank you for that wonderful welcome. It really is a privilege to be able to speak to you all tonight. As Annie mentioned, I'm a physio working with people in chronic pain of all different types. But tonight we're really talking about taking a whole person approach to managing chronic pain in multiple sclerosis. And you may or may not know, but chronic pain is a pretty big problem in Australia in the general population. So even 1 in 5 people just in the general population will experience chronic pain, and I'll talk a bit more about what chronic pain is in a minute. But we know that people who experience MS are even more likely to have chronic pain. And the figures vary a little bit depending on the studies, but it looks somewhere about 60% of people with MS do experience chronic pain. So it's obviously a very important topic to talk about. So what we will cover tonight, firstly, is a bit more about, well, what is pain and how does it work? Because that can be really helpful in understanding what you're experiencing. Then we'll look at, okay, well, what contributes to chronic pain in MS? And as we'll see, there's lots of different things that have the potential to contribute. And then from there, number 3, managing pain. And we're going to look at managing pain from a whole person approach, so a really broad approach to managing pain. So that's what we'll cover tonight. So first up then, what is pain and how does it work? So first up, I want you to think about, have you ever had a time or a situation when you remember having some damage to your body, but you didn't experience any pain? This might be something simple like you get in the shower and you notice, oh, where did that bruise come from? I don't remember getting that. Or you might be shaving and you don't notice that you've cut yourself until you start to see blood. So most people have had some type of experience in their life where they've had some damage to their body, but they didn't have pain, which doesn't always fit with our what we think of our understanding of pain. Some other examples might be, you've probably heard of people who can kind of walk on hot coals and not experience any pain, or in the sporting arena, you know, just in that picture, you've got about 6 big guys on top of one another. It's painful to me, but they all look pretty happy. Or you might have heard of someone who's played their grand final and not realised until afterwards that they were actually playing on a broken bone or something like that. Other common stories are like stories in war of someone getting shot and not realising, or a shark attack where they, you know, they just feel a bit of a tug, they don't have any pain, but the time. Another example that's starting to become more known is when we look at scans and things. So how this started was some people had some skin cancers on their backs, some melanomas, and so they put them through a scanner, through an MRI machine, to take a look at how deep that cancer had gone through. And as well as imaging the skin, they could also see their bones and their discs and their joints and everything in their back. And the radiologists had a look and went, oh, wow, all these people must have a lot of back pain. You know, we can see a lot of degeneration, a lot of disc bulging, some compressed nerves. But then when they asked these people, the majority of them actually didn't have any pain. So that led us to doing studies looking at scans of pain-free individuals, and you get some surprising results. So if we just take 50-year-olds, if we put 50-year-olds through an MRI scanner, 50-year-olds who have no back pain, 80% of them will actually have disc degeneration and 60% will have disc bulging. So what's going on here? We can certainly have damage to our body and not experience pain. What about the opposite? Has anyone had a time where they've had pain, but it turned out they didn't have any damage to their body? One example for any women that have kids that are listening might be early labour, when the uterus is making some strong contractions, but it's not actually causing any damage. But most people find that pretty painful. So that would be one example. Stepping on Lego, again, that's probably one for people that have got kids, but that's pretty exquisitely painful, but doesn't cause any damage. Or you might think of some examples where you had a little bit of damage, but the pain was really out of proportion, like a paper cut. You know, they really hurt, but it's a pretty tiny little bit of damage. Another interesting story that I always remember is one of a builder who jumped off a fence and landed on a nail, and the nail went through his boot, and he was in extreme severe pain, as you'd expect. He got taken to hospital, had to have a lot of anaesthetics. Eventually they're cutting the boot off, and they realise the nail went between his toes. There was no damage at all, but he was in extreme pain. So the first thing, I guess, to learn about pain is that it doesn't always match up to the amount of damage in our body. So pain is not a detector of damage. Instead, pain is a protector. So pain is there to protect us from things. And people who, in fact, there's a rare condition of people who can't experience pain, and unfortunately they tend to die very young. So we know that we do need pain there to protect us, but it doesn't necessarily equate to the amount of damage. The next thing I want to mention with these cute little pictures of ducks, and then the picture on the bottom is a big flock of birds called a murmuration when they fly together in sequence, is how we think about a lot of patterns in our lives can be useful when we're thinking about how pain works. So on the one hand, some patterns of behaviour can be linear. So say like a little ducklings following their mother duck. In a linear pattern, there's often a dominating starting process, and then things follow in a set order. So something has to happen or be completed before it goes on to the next phase. So one duck follows the next duck, follows the next duck. Or another example might be digestion. You know, you chew the food, swallow it, goes down into the stomach, into a series of organs before coming out the other end. On the other hand, we've got patterns that are emergent. Emergent patterns are things that occur when a collection of objects interact with each other in a complex way. So like that flock of birds that we can see down the bottom. And in an emergent pattern, the players or the agents or the contributors, so the birds in this picture, they all have reasonably equal status, and the overall outcome emerges from the combined activity of all the agents. So one example might be a traffic jam, where one car breaking down can set off lots of different effects throughout the city, or the weather would be another example of an emergent pattern. Why am I talking about ducks and the weather? Because pain is more like the latter. So pain is more of an emergent pattern, which means that it's complex. You know, we often like to think of, you know, damage goes in, pain comes out, which would be a linear process, but unfortunately pain is a lot more complicated than that. But the good thing I like to think about that is it means that there's a lot more that we can do about it, a lot more that we can change about it. So what is pain then? You'll have to excuse me, I'm just having some water as we go. So the official definition from the International Association for the Study of Pain says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. I find that a little bit of a mouthful while it is correct. So I've simplified it here to pain equals sensation plus distress. So it's always felt in the body, but we don't like it. You know, I'm yet to meet a patient who says, yeah, I've had this pain for a long time and it's great. You know, nothing, no problem there. The other thing to touch on here is that pain is always real. So pain is never kind of imagined or all in your head or anything like that. Pain is always real and it's absolutely felt in the body. So even if you don't have that body part anymore, like in the case of phantom limb pain, you could have lost your leg, say in an accident, but you could still feel pain in that leg. And that is absolutely still real pain. It's felt somewhere in the body. It's felt in a leg that doesn't exist anymore. It's still real. The other thing with what is pain is they do then divide it up into some subtypes. There's 3 subtypes that are recognised, which would be nociceptive pain, which tends to relate more to damage to the body, and I'm going to talk more about these in detail in a minute. Neuropathic pain, which tends to relate more to damage to nerves, and some MS-related changes could be a part of that. And then nociplastic pain, which relates more to changes in the function of nerves and how they process things. And the tricky thing is that all 3 are often occurring together and in a combination. So what is chronic pain then? Because that's really what the focus of this talk is today, is chronic pain. And that's pain that's lasted for longer than 3 months. So sometimes people get confused between acute and chronic pain and thinking it's about severity, but it's just about time frame. So acute pain is pain that has lasted for less than 3 months. Chronic pain has lasted for more than 3 months. And you could have a mild chronic pain, you could have a severe chronic pain, you know, the intensity could fluctuate, but it's really about that time frame. The pain doesn't necessarily have to be present every day, but probably it would be there for most days to be considered chronic pain. And it could be in just one location, it could be in 2 or multiple locations, or it might even move around in different locations. So how does pain work then? So I'm going to go through a little bit of the science of how pain works. I've got some resources at the end if you'd like to go through this again in a bit more detail or a little bit slower, and they're there at the end for you. So first I'll just orientate you to the image. So up the top here we've got the brain, the cerebral cortex. The base of the brain is just called the thalamus there, so that's just kind of where all the messages come in. You've got the spinal cord running down through the center, which is inside your spinal column, and then you've got peripheral nerves. So we've got lots and lots of nerves going out through our body. We've just depicted one main one here going down out into the arm, and then at the end of all of our nerves we have little detectors called nociceptors. One other little general point to make here is you'll notice that nowhere on the picture and nowhere will I say a pain receptor or a pain fiber or a pain message. And that's because these detectors, they don't detect pain. They can only detect damage or potential damage, and they can send a message of potential damage, but it's not pain until the brain decides and the brain produces. So we'll go through that in more detail, but it's important to know that the pain doesn't start out in the body. At that point, it's just an electrical signal. So going through each of those steps in a little bit more detail. So these nociceptors are located on the ends of nerves. I often like to use the word danger receptor because that's all nociceptor really means. They're receptors that detect potential damage to the body. So that could be pressure, it could be chemical changes, or it could be temperature changes. If enough of those little receptors open, then they will send a message called a danger message, or the technical term is nociception, up through the nerve, and that will head up to the spinal cord. These messages can become what's called sensitized, which means the volume of the message gets turned up. So for the same number of little danger receptors that are open, more messages get sent towards the spinal cord. And that peripheral sensitization tends to happen in the presence of things like inflammation or things like that. So say if I've tripped over and sprained my ankle and got a lot of inflammation there, then I will get some of this sensitization happening. And that's a normal process to protect the body. Once the messages get to the spinal cord, then there's lots of nerves from the body that head up to the brain. So it's a little bit like a roundabout, I guess, and you've got lots of messages coming from lots of different areas. The message will then, after it's hit that roundabout, head up to the base of the brain, to the thalamus. The interesting thing here is that for every one nerve that heads up, there's over 400 that head back down again. And their job is typically to kind of dampen signals down. Because in the normal situation, if we let all of those signals come up all the time, we'd be overwhelmed and we'd be bombarded with signals. So sitting here at the moment, I don't really want to feel the pressure of my legs on the chair, being aware of my socks or my shoes on my feet, things like that. So even though all those messages are still coming up, there might be pressure in the bottom area coming up that will let me know that I need to wiggle a bit to change pressure. But normally the brain sends signals back down to dampen those down so it doesn't get overwhelmed. When sensitization occurs, and in this part of the body it would be called central sensitization, the volume of this message gets turned up. So instead of those nerves coming back down, dampening things down, they can now start to wind the message up instead. It's a little bit like a volume dial on a radio getting turned up and up and up so that we get more and more of those danger signals hitting the brain. In multiple sclerosis, we know that damage to nerve cells due to MS, say in the spinal cord or in the brain, that those changes can also cause some of these danger messages to be sent. So that can be another contributor here to more of those messages heading up to the brain. Once the messages get up to the brain, they reach the base of the brain called the thalamus, and then the brain has to kind of weigh things up in this situation. So it takes all these messages from the body, thanks body, and kind of says, all right, how dangerous is this really? And it's a little bit like, I think of it as like running a Google search. What do we know about this situation? And it will come up with thousands of hits, some of them really relevant, some of them maybe a little bit less relevant, and the brain has to kind of weigh all that information. So some of that information might be coming from your environment, how hot is it, how cold is it, what else is kind of situated around me, my senses, what can I see any other danger, what can I hear, what can I smell. It'll also access other parts of the brain. So our memories, have we been in this situation before? What happened then? Has my brother, sister's uncle been in this situation before? And what did they say about it? Learning, what do I know about this situation? It'll also take into account our beliefs and our moods. So how are we feeling at the moment? Have we been having a good day? Are we already kind of feeling a bit over things? The brain very, very quickly, and not at a conscious level, this all happens, I want to emphasize, at a subconscious level, the brain will analyze all of this information and then it decides it may or may not produce pain. Again, not consciously, but it takes all this information in and it might decide, okay, this person needs protecting, we're going to produce pain in this situation. Or it might go, it's not actually that dangerous, we're not going to produce pain. Or perhaps there's another priority at this time and that's why it doesn't produce pain. Sensitization can also then occur in the brain, and this is where the brain is more likely to produce pain. So even for less of those danger messages coming up from the spinal cord, it can become more and more likely to produce pain. And that particularly occurs through processes like learning and things like that. So what does all this science mean? So to sum it up, hurt doesn't always equal harm. So danger to your body doesn't always mean it will hurt, but at the same time, pain doesn't always mean that there is danger in the body. So pain depends on how much danger your brain thinks you're in and not how much you're really in. So we've said pain is a protector, not a detector. Pain is complex. And then when pain persists, the pain system becomes overprotective. So those points in time where things can become sensitized, we know when pain persists, when it lasts for more than 3 months, then those volume dials start to get turned up. The brain wants more information, it pays more attention to any of those signals, and it starts to become overprotective.
Laura, I've just got a couple of questions that have come through.
Sure.
Okay, Larry has asked the question, is burning feet a pain? He's had burning feet for about 15 years. And he's asking, is there anything that can be done about this?
Yep, great question, Larry, thanks. So I'd say burning feet is definitely a type of pain, yes. In terms of what can be done about it, I'd say that, again, looking at the whole person approach, which I'll talk more about a little bit towards the end, is still going to be relevant. But yeah, burning feet would definitely be a type of pain that fits through there. And in terms of what we've been talking about with how pain works, is it's likely that that protective pain system has been wound up over time and become overprotective, so that even if there's not ongoing damage in the feet, or perhaps there is some damage, I don't know your situation, of course, individually, but it's winding it up and making your experience worse for you. So we want to look at things, which we'll talk about in the second half of the talk, that can start to wind that sensitivity down again.
Okay, great. Thank you, Laura. Another question has come through from Nancy and Steve, and you may cover this further down, further through the webinar. But the question is around Botox, and is that good for constant neuropathic pain in the legs, especially when at rest?
Yep. So Botox, we'd say, is a biomedical treatment for pain, and overall for chronic pain, so pain that's been there for more than 3 months, biomedical treatments don't tend to work that well in the long term. So they might be helpful in the short term, but they tend to wear off, and you tend to need to have repeated treatments. It's just the first thing to know. The other thing is that Botox tends to be mainly used more for spasticity, so when the muscles are having a lot of trouble relaxing. So if that is part of that picture, then maybe that might be something to look at. But there's probably lots of other things that can be done as well. And at our pain clinic, for example, we don't offer Botox treatments because there's not enough really good quality evidence that they work well in the long term, and there's other things that tend to work better. But some neurologists will offer them for some particular types of pain.
All right, great. Thanks, Laura. Just had a comment from Melanie saying that she also has burning feet, and Sharon has mentioned that she uses an ice pack for her burning feet, and she finds that it works quite well.
Yep. And we'll talk about things like ice packs and things like that a bit down the track, because definitely some people, like Melanie, might find them really helpful, and other people might find them less helpful. It does depend a little bit.
Okay, great. Thank you, Laura.
Thanks, Annie. That's all right. So I've talked a little bit about the science of how pain works, and suggested that if pain's been there for more than 3 months, it's likely that the pain system has started to become a bit overprotective. But how do you kind of figure out if that applies to you? You know, how do I know if my pain system is overprotective? And I want to thank Lorimer Mosley, who's a professor of physiotherapy and of pain science. These slides are adapted from some of his, and you'll see some resources from him at the end. So one clue to start off with is to think about the amount of pain-free movement that you can do. So in a normal protective pain system, you should be able to do quite a bit of movement before your system kicks in to protect you and produces pain. You know, you can walk for however long, and then your system kicks in and starts to give you some foot pain or some knee pain or some aches, and you think, okay, I'll have a rest. In an overprotective pain system, the amount of pain-free movement tends to be much, much less, very, very small. And in some cases, it might be, you know, virtually nothing, a minute or something like that. So that's one example. The next is thinking about the amount of pain-free time being still. So in a protective system, that's usually quite a lot of time. You know, someone might be able to sit for 2 hours or so. It's quite a bit of time before a protective pain system would kick in and encourage that person to move. In an overprotective system, even being still often starts to cause pain. So you might not be able to sit for very long anymore. You might not be able to stand for very long anymore, and find that you need to continually change positions. So that's another little clue that maybe the pain system's become overprotective. The next one will be pain caused by weather changes. So in a protective pain system, that might cause a small amount of pain, especially if you've got MS, but not drastic amounts of pain. In an overprotective pain system, that can be really big changes, and that might be due to the heat, the cold, the humidity, the rain. Could be lots of different, you know, different people find different types of weather aggravate their pain, but the weather causing big changes in the pain system. The last one I put is pain when I ... because this tends to be quite individual, but they're things that we don't normally associate with kind of contributing to pain. So say, for example, if I've had a car accident in my history and I drive past the roundabout where I had that accident and I feel a big increase in my pain, that would be very typical of an overprotective pain system. Whereas in a protective pain system, we wouldn't expect that driving past a certain place that would cause me pain. You know, I've had other examples of people who say, oh, I just have to look at the vacuum cleaner and my pain hurts. So other types of cues, whether it's thinking about a situation, watching other people do it, seeing something, or going past a certain place, those types of things aggravating pain can be another sign that perhaps the pain system has become overprotective. So we'll move on then, number 2. So we've learned a little bit, one, about how does pain work. Number 2, contributors to chronic pain in multiple sclerosis. And I put this picture of this cake and all the ingredients up on the left just to illustrate that everyone here is going to be a little bit different. We're all going to have a bit of a recipe of contributors to pain. So most people might have some flour, some sugar and some eggs in there, but one person might have 3 eggs, one person might have 1, or someone else might have some vanilla in there as well, or someone else might have some strawberries. So I'm going to talk about lots of different possible contributors. Of course, I don't know you all individually, and you'll probably hear some that you think, yeah, that really resonates with me. I think that's probably contributing to my experience of pain. And then you might hear some others where you think, no, that's not so relevant to me. But everyone will have this kind of recipe of lots of things that come together that contribute to their pain, which is why we use the word contributors rather than causes. Because again, going back to that kind of linear versus emergent, unfortunately with pain, it's not as simple as X causes Y pain. It's more like X plus Y, a little bit of Z and some G on this occasion causes Z pain. So this is our whole person hand model. The reason we've got it on a hand is to make it easier for us to remember that there's 5 parts. So we've got the biomedical, the mind body, connection, activity, and nutrition. And by having a model like this, it makes it easier to not accidentally leave out any parts. So you can always kind of scan your situation and go through the 5 components and think of, okay, what's happening for me at the moment? Then we're going to use this same model a little bit later on after we talk about contributors to then talk about things we can do about it, okay? So the other thing I'll just mention here too is when talking about contributors is that some of these things may have contributed to the start of the pain, and then there's others that might not have contributed to the pain beginning, but they're now contributing to the fact that the pain's ongoing. So it can be a bit of both here. So in the biomedical sphere, so definitely in multiple sclerosis, one contributor can be damage to the nerve cells in the spinal cord and the brain. And of course, as you know, that can fluctuate with what's happening with your MS at the time. So that can be one contributor to pain. Another contributor is the nervous system sensitivity that we've just talked about. So if the nervous system has become overprotective, which is highly, highly likely as pain persists, then that's another contributor here to ongoing pain. Another one can be medication problems. I mean, particularly here, medications relating to pain, not medications relating to other things. So there's some medications, particularly the opioid or morphine-based medications, where if you're taking them regularly over a period of time, they can then actually start to cause more pain. So something that's known as opioid-induced hyperalgesia, where we think we're giving people a painkiller, but it's actually not. It's actually making pain worse. Next, in the mind-body section. So mind-body relates to quite a lot of things. Firstly, I guess mental health. We know there's quite a strong link between pain and mental health. Of course, having pain is not a pleasant experience. So about 50% of people experiencing chronic pain do have depression. Many will also experience anxiety, stress, feelings of anger or irritability. It's not uncommon for people to have had a history of trauma in their childhood or throughout their life. Also to have poor sleep is not uncommon. And it's a lot of people understand, of course, it's natural that if you're in pain, it's very hard to sleep. But we now know that poor sleep actually makes pain worse. So it can be a bit of a cycle there with poor sleep as well. And then less helpful thinking is the other thing in the mind-body section that can be contributing. So that's thinking like having lots of worried thoughts or things like that, and not knowing how to deal with those. So they're things that can contribute here in mind-body. Some people with MS find they have some of those thoughts or feelings relating to their MS as well, and that can then contribute into pain as well. So it's a bit of a grey area. The next finger is connection. So social isolation hurts, disconnection hurts, and connection's a very strong predictor of our health. So we certainly find that a lack of connections, whether that's to other people, to places, to culture, that can be a strong contributor to pain as well. So that might be social isolation, that might be relationship issues or intimacy issues. It could be contributing less to work and life roles, or it could be being less linked to country, to your culture, or to nature, for example. And again here, with the overlap with MS, a lot of people find, well, maybe some of those changes happened related to my MS, or it happens in times of flares or setbacks, but then that then interferes and impacts on my pain as well. So the two can be very strongly related there. The next finger is activity. So a lack of regular physical activity, and I know, of course, that can be much harder when you've got MS, but still a lack of regular physical activity we know contributes to ongoing pain. Muscle weakness also contributes to pain. Too much sedentary behaviour, so too much lying down, can contribute to pain, and also over-reliance on passive aids, and I'll talk about that a bit more specifically in the what to do about it section about what that means. And the last finger, last but certainly not the least, is nutrition. So we know being overweight or obese can contribute to pain, particularly weight held around the tummy area can contribute to inflammation in the body, which seems to have quite a link with pain. A high sugar intake or a lack of vegetables is linked with pain. And then the other thing here that we tend to talk about is excessive caffeine or smoking or alcohol all have a link with pain as well. That's a lot of possible things that I've just talked about here, and that probably hasn't even covered, you know, every single possible one of them. There is, in the extra resources at the end, there's a link on our HIPS website that has a little kind of self-assessment sheet with tick boxes going through a lot of these things. So if you think I want to spend a bit more time going through this, either on my own, or you could take it to your health professional and go through it together and think what's contributing to my pain for me, for my experience at the moment, then that's a really good resource that you can use as well. And that assessment sheet then, it links to the what to do about it that I'll talk about next as well. So to sum that up, many things contribute to chronic pain. Which leads us on to managing the pain. So what can you do about it? And this really is about things that you can do more so than things that I can do or someone can do for you. What are things that you can do? The evidence really strongly supports that self-management is the most effective way of pain management. And I've put the picture of the jigsaw puzzle in there because we've just talked about a lot of things. We're going to talk about a lot of things you can do. It can sometimes feel overwhelming. And I often like to suggest people take a jigsaw puzzle approach of just putting one or two pieces into place at a time and slowly building up that jigsaw puzzle as they go, rather than trying to kind of do too much all at once and then it feeling overwhelming. So with managing your pain, it can be helpful to focus on expanding your life around the pain. So what do I mean by this? So if we have a look at this little picture, we've got pain is the red circle in the center, and then you've got life is a bigger circle around it. And what a lot of people tell us is that over time, life shrinks around the pain. There's less things that you can do, and the pain is kind of more and more in your face, more taking up what you can do. It's very natural and very tempting to focus all our energy on shrinking the pain. I'm trying to find things that kind of get rid of it or decrease the pain. Unfortunately, the evidence suggests that this doesn't work very well in the long term. It's a little bit like pushing a beach ball underneath water, and it kind of tends to pop back up straight away. What works better is focusing on expanding life back out around the pain. It may not get back to exactly what it was before. It might look a little bit different, but just trying to focus on what you're able to do. And then pain, actually, ironically, then tends to shrink. Or some people say, yeah, the pain's still there, but it doesn't bother me as much, or it's changed in quality or something like that. So I think it's useful to understand the reasons why the focus often tends to be on things you can do in your life. It's not to be callous or cruel or anything like that. It's because treatment so it can help to focus on improving your function. And of course, that's acknowledging that within MS, there is going to be potentially some limits depending on your situation and what's happening for you in your MS at the moment. So we'll go through each of these 5 fingers. So the first one was biomedical. So the first point I've got up there is to optimize your MS treatment. So of course, if that's more under control, then there's going to be less contributors from the nerve changes to your pain. I'm not going to go into any more detail than that because that's not what this talk is about, but knowing just that your treatment for your MS is in a way a treatment for pain. The next thing I've put up there is something that we find is really crucial, is finding a GP that you trust and connect with. So that's someone that you can see regularly. You might often have questions about a lot of these things that you can really work with alongside, because it can be quite a complicated area. The next thing down, it says medications for pain are not very helpful in the long term and often have side effects. So I'm particularly talking here about medications for pain. So I'm not talking about MS medications or other medications, but medications for pain, and particularly opioid-based medications, the evidence says that they don't work in the long run. So they stop working or they run out of puff, and they can have a lot of side effects. So I already talked about one of those side effects. Oh, sorry, I'm getting a bit tongue-tied. One of those side effects can ironically be to actually turn that nervous system sensitivity up and make pain worse, but they can have lots of other side effects as well, the most common one being constipation, but they can also have things like drowsiness, things like that. It's harder to gain strength, so things that can make life even harder when you've got MS. Unfortunately, in the biomedical section, there are no quick fixes. But the good news of that is that slow, steady changes do result in change. And so in the biomedical section, the biggest contributor often is that wind up in the nervous system, the pain system becoming overprotective. And how we then start to wind down that nervous system sensitivity is by working on the other 4 fingers that we're going to go through now. So in the mind-body section, so getting support from a psychologist can be really helpful. Of course, that can be really helpful if you're experiencing depression or anxiety or anger or any of those types of things, whether related to MS or related to pain or both. But even if you're not experiencing those, psychologists are really useful people at helping you work through some of these connections. Oh, sorry, my watch is just going off. They're also experts in sleep and sleep habits. So there is quite a lot of things we can work on to help to improve sleep. Unfortunately, sleeping tablets don't work very well. They might get you to sleep, but they don't help the quality of our sleep. But there's lots of other things like cutting down screen time before bed, reducing caffeine, keeping our bedroom in a cool, quiet place, things like that that can help our sleep. And then the other skills that psychologists are really experts on and that are really helpful for pain, even if your mental health is quite good, is things like mindfulness. So that's often working on training our relaxation response. So working on breathing exercises, meditation, things like that can actually help to turn that nervous system sensitivity down and help with pain. The other thing just to quickly mention about mindfulness is sometimes people feel frustrated around the word acceptance. Mindfulness is often about accepting that things are as they are at the moment, but that's not resignation. That's very different. So accepting things are as they are now, but there's definitely the possibility of change. The other thing to talk about with mind-body is psychologists often work on turning towards the pain, which is a very unnatural thing most of the time. Our reaction tends to be to avoid it or to push it away, but learning the skill to be able to turn towards it in a calm and mindful way can be a really helpful skill in managing your pain. As well as seeing someone face-to-face, other options for psychology and the mind-body area is internet treatment programs, and I've listed those at the resources at the end. So there's great internet treatment programs available. Some are free, some are very low cost, specifically for pain, and then there's also other ones for depression, anxiety, things like that. Moving on then to connection. So when we talk about connection, we mean connection to other people, connection to the places around us, and connection to purpose. So we've mentioned that disconnecting hurts, and finding ways of reconnecting can be a really useful way of managing pain. So some examples might be, figuring out is there a way that I can work in some capacity, or if not, can I volunteer in some capacity? We know that volunteers get a huge amount of health benefits from it, and we know that it can be really helpful for pain. For other people, connection, working on that might mean working on their communication skills and how to kind of, advocate for themselves and things like that. It might be getting specific relationship counselling if you're having relationship problems, things like that. It could also mean spending time in green spaces. So we know getting outside is really helpful for managing pain, and pets can be another one in there as well. You've got the picture of the lady with her dog. Spending time with pets can be a really useful way for connecting and managing pain. So activity. So this is obviously my bread and butter. What I spend the most time working on with people is how can they manage their activity. So lots of people in pain tell me that sometimes they get frustrated and kind of push themselves because they've got a big task they want to get done, or maybe they're having a good day and they think, I've got to try and get as much as I can done, now while I can, but then they pay for it afterwards and they crash. Does that sound familiar to anyone? We often call this a boom and a bust cycle. And it's very natural when you're experiencing pain, and probably even more so with MS symptoms as well. But it can become a bit of a trap and a bit of a roller coaster. And over time, it tends to lead us to become weaker, and also to become our pain system to become overprotective. So the key message with physical activity is that consistency is the most important thing. It's better to do a little bit less to find a manageable amount and do the same amount each day, do it really regularly, really frequently, and then very gradually build up over time. So you might find that on a good day, you've almost got to hold yourself back a little bit, not do too much, but on a bad day, you might have to kind of push yourself along a bit and try and get that amount still done. Of course, I acknowledge here that at times of flare-ups with MS, it's going to be much harder to do that than at other times. I've just listed there too the three kind of categories of physical activity we tend to talk about when it comes to pain. So cardiovascular, strength, and mindful movement. And it's really important that we try and get a little bit from each of these three buckets. So cardiovascular would be anything that gets kind of your heart and lungs working more. You find it's a little bit harder to keep up a conversation. Walking would be the most common example, but it could be swimming, walking in water, riding on a stationary bike, could be lots of other things. Strength is anything where you've got to move your muscles against resistance. So we often use in our programs lifting bottles of water. It's a really easy, accessible way, or cans of food to get a bit of strength training in, but it could also be doing some body weight training, practicing getting up and out of a chair, or it could mean going to a gym and lifting some weights as well. And thirdly is mindful movement. So this is movement, unlike the first two where we're really striving, the third one is a non-striving type of movement where we're more just letting ourselves be in the moment. There's a lot of focus on the breath. So there's quite a bit of overlap with the work that you do in the mind-body section. And it tends to be things more like Tai Chi or gentle yoga or things like that. And that can be a really useful type of movement for calming the nervous system down as well. So consistency is the key. And the last little point there is about gradually reducing sedentary time. So we know the couch is one of our biggest killers in Australian society. I know it's not easy to get off the couch, particularly if, depending on where your MS is up to and things like that, that may or may not be an option. But even sitting is going to be much better for us than lying down all the time. So being sitting, we're upright against gravity, compared to when we lie down, we take gravity out. So gradually reducing our sedentary time or making it as less sedentary as we can is also really helpful for managing pain. Now, I said I'd talk a little bit more about passive aids and devices. It's important here to find the right balance, I think, is the key. So what do I mean by passive aids and devices? I mean things like walking sticks, wheelchairs. I also mean things like ice packs, heat packs, TENS machines. So any kind of thing or device that you use to manage your pain. So there's some things that can be really helpful. If you're using a walking stick to prevent you from having falls, and that means you can get out and do more walking, of course that's fantastic and you should keep using it. But if you find you're relying on something more and more, and it means that you're just is increasing your sedentary time, reducing your physical activity and promoting avoidance, then that's probably something that's going to be less helpful and contributing to pain. So we mentioned a little bit earlier about ice packs and heat packs and things like that. It's okay to use some of those things some of the time, but if you find that they're gradually taking up more and more of your time and you're really relying on them, sometimes they can start to become a bit of a problem in of themselves. We've also always got to just be a little bit careful with a lot of those things, heat packs and ice packs, making sure you've got the sensation in the area, that you don't give yourself a burn, things like that. But generally those passive aids and devices, if they're allowing you to get out safely and move more, on the balance, that's probably a good thing. If using them means you've got to spend more time lying down and avoiding things, then maybe it might be less useful and you could consider, okay, could I try and use it a little bit less over time? And then nutrition. So we've mentioned that having weight around the tummy area, increased waist circumference, is associated with something called metaflammation, which is more inflammation throughout our body, which we know has a link to pain. But the good news is that healthy food reduces that inflammation. So vegetables are really important in that. So for most of us, it's trying to get some more vegetables and water in and getting a little bit less sugar, caffeine, alcohol, or smoking. And obviously, shopping, preparing food, prepping, standing and cooking, all of that can be really challenging when pain is present, and it can be even more so challenging when dealing with MS as well. So sometimes it can be useful to see a dietitian and work on strategies for some of that, or just knowing some quick, simple shortcuts, like frozen veggies are just as healthy as fresh, for example. So having lots of that in the freezer can be a good go-to, things like that. So the last point there is that use a whole person approach to managing pain. If we just kind of zone in on one section, so if we just zone in on the biomedical treatments, for example, often we don't get as far. Whereas if we look at everything that's happening both in our MS and in our pain, then we tend to find a much broader and longer lasting approach to pain. That is, tends to be slow to make changes, but is long lasting. Then here's a link to those resources that I've mentioned throughout the talk. So Explain Pain is a book that goes through in more detail the science of pain. It's really easy to read. It's not a textbook by any measure. It's a really great book. The next few websites are all just some little videos if you prefer to watch YouTube links and things like that to learn about pain. There's a healthy eating quiz which has been developed by professors at the University of Newcastle here, which can help you to figure out, okay, is there anything missing from my diet and what should I do about that? And that's free. The next one there is talking about habits, because a lot of the things in that whole person approach are about slowly changing some habits, which we all know is not easy. So that website's got some great tips about that. The next one there is the HIPS website, so that's where I work. And on that website, you'll find that kind of self-assessment sheet going through what contributors might be contributing to your pain, so you can really individualize it for you. And it's also then got a column of, okay, then what things am I going to tick that I might want to do about it? And then those two websites have online treatment programs, both for pain and also for other mental health conditions as well. And then last but not least, thank you. So I hope today has brought some hope that with planting seeds and slowly watering them over time, that things can certainly grow and blossom. That pain, even if it's been there for decades, it can certainly change when we use this whole person approach.
That's fantastic. Thank you, Laura. That was a really great presentation. I especially like the way you describe what pain is and how it affects and how movement of it affects our body and how the messages are sent to and from the brain. That was really interesting. We have got a few questions, and I will relay them through to you, Laura, before I take control and go through the final slides regarding our MS services. Yep. So firstly, Sharon has mentioned that she's on a pain medication. She's on 75 milligrams of pregabalin. I'm not sure if that's the correct spelling. Twice a day. Yep. And she's now getting breakthrough pain. So I know you mentioned earlier in the biomedical slides that over time pain medication no longer seems to work. So it sounds like this is the case in Sharon's case as well.
Yep, so a lot of people might be on medications like Sharon, like pregabalin, which is a different class of medication. I know I mentioned the opioids. The pregabalin is an anticonvulsant, so they were discovered from treatments of epilepsy and things like that. And they slow some of the connections between nerves down. The research would tell us that those medications seem to be helpful for around maybe 1 in 7 to 1 in 10 people. So that means I've got to give it to 10 people for one person to get a benefit. And that over time, that one person, the benefit often then does start to wear off. But I'm not a doctor, so I won't give any specific medication recommendations for any individuals. I'd always say go back and chat to your GP, or if they're not sure, ask to be referred to a pain specialist about it. But that would be not an uncommon experience for someone to start a medication, maybe find it helps a little bit in the beginning, and then it seems to kind of run out of puff and stop working.
Yes, certainly. Thank you, Laura. Melanie's also mentioned that she's used it in the past and it did seem to increase her pain, and she experienced mental health issues as well. So
yeah, I think that's a really good point, is that a lot of these medications can have some significant side effects. Yeah,
that's right. And if you have any further questions about any medications, we do have a couple of MS nurses that are available on the advice line, and you can contact them through the MS Connect number, which we'll go through a bit later in the services slides. So a few more questions to get through. Melanie's saying, can chronic pain cause inflammation in bone? E.g., pain in the feet, does it cause inflammation in the bones of the feet?
Yeah, that's a tricky question. I guess with inflammation, we're still learning more and more about it at the moment, and certainly inflammation can contribute to pain. Whether or not the pain then causes more inflammation, I'd be less confident about. But we know that there's lots of other things that can contribute to widespread inflammation as well, which are things like poor nutrition or not enough veggies, things like that. And also just chronic stress can actually contribute to chronic inflammation.
Yes, of course. Okay, thanks, Laura. Linda is asking, is nerve denervation still offered as a possible treatment for pain? Linda had this procedure done twice and did receive a very favourable outcome.
Thanks, Linda. I probably can't necessarily answer that in terms of your specific area. My service where I work for at the Hunter Integrated Pain Service rarely offers those types of procedures except for cancer pain, so where someone is expected to pass away in the coming weeks because of the fact that it can work in the short term and then it just tends to come back. But that's not to say there are services out there that do still offer it, particularly more in the private sector, but it's a bit variable depending on location.
Yes, of course. All right, Anna's asking, can you give an example of turning towards pain? I think at one point during the mindfulness finger, you mentioned turning towards pain. Yep,
sure. That's a really good question. Thanks, Anna. So to start this process, our psychologists often work on some kind of breathing and meditation techniques. So you might do, I don't know if you're familiar, but maybe do one of those short practices. And then you would actually take your attention to your pain. So if I use the example, a few people have brought up burning foot pain, for example. So if you're lying down, you're listening to a guided meditation or doing one yourself, you're breathing, then you actually focus on that pain in your feet, and you'd go through some questions in your mind like, what does this pain feel like? What is the temperature? What is the size of it? Is there a color? Is it throbbing? Is it pulsing? And go through kind of a series of actually really kind of staring it in the face and trying to describe it and notice whether or not it changes or not. And you just almost sit with the pain. Well, often people find this quite tough, so they might start off with doing that for maybe 10 seconds or so and go back to their usual kind of meditation technique, and they build up that process. Does that make sense? Feel free to type another question if that.
Yes, I hope that's made sense, Anna. Let us know if not. So we'll just move further on to more questions, and Anna, please feel free to type in more if you wish. Melanie's asking, what about exercises when you're in an electric wheelchair?
Yep, that's a really good question as well, and that's why I'm sorry the presentation is of course in some ways a little bit generic, and what different people can do is of course going to be different. You're obviously going to have to get creative. Often hydrotherapy might be an option, or I know the warm water can bother some people with MS, so even some other type of cooler water treatment, or you might need to find a way of making the exercise a little bit easier. So often working with someone, maybe getting referred to like an exercise physiologist or someone like that who can assess you one-on-one in your situation and provide some guidance on how to do those exercises would be my suggestion.
Okay, great. Thank you, Laura. Now, Lynn is just asking if the resources can be emailed through. Lynn, I will let you know that we have sent through the copy of the slides through to everyone via email. So those resources will be available on that. If you haven't received them, please send an email through to education@ms.org.au, and we'll forward them on, no problem at all.
And Annie, I just realised I didn't mention with the resources, the first one being a book. Most libraries do have that book. Otherwise, if you Google it, you can purchase it online, and they also have an ebook version for iPads.
Okay. Oh, that's great. Thanks, Laura. We've had a few comments come through. Janet's saying, very interesting, thank you very much. Sharon's saying, thank you for the talk, it was most informative and helpful. Mary's saying, thank you very much. Another question's come through from Anna as well as Teresa, asking about CBD oil for people with MS.
So currently the Faculty of Pain Medicine, which is all the specialists, pain medicine specialists around Australia and New Zealand, have got together and released a statement regarding cannabis or marijuana for chronic pain. They currently don't support it, and neither does the Hunter Integrated Pain Service at the moment, at this stage, because the evidence really doesn't support that it works. I know a lot of individuals report that they find it helps them, but when we've looked at that at studies where are controlled studies, which means that one person gets the real cannabis and one person gets a placebo, there doesn't really seem to be any difference between the two. And the other thing we see is that there is quite a lot of side effects with it as well, including risk of psychosis, things like that. And fundamentally, It doesn't seem to help people get back to living the life that they want to live. So we don't recommend it. Of course, we'll always be open to changing our mind if the evidence changes, but that's the evidence that we've got in our hands at the moment.
Okay, thank you, Laura. Lynn has mentioned that her exercise physiologist has a treadmill that inflates with air and actually takes 80% of her weight off, enabling her to walk much easier. So that sounds fascinating.
Yeah, there's a few of those, and there's, I think, even some water ones starting to become around. I don't imagine they're cheap. We don't have one at my facility, but yeah, I am aware of them, and if you can access that, then that's great, Lynn.
Yeah, that's fantastic.
They're often changeable too, so you might be able to go from 80% to 75%, or things like that.
There you go. Lynn's just typed in $100,000 it costs.
Yep, doesn't surprise me.
Yeah. Okay, I am mindful of the time, so I'm hoping you can all see my screen. So as I said, if you have any further questions, please don't hesitate to call us at the MS Connect line. That's a free call, 1800 042 138, or you can email through to msconnect@ms.org.au. I'm just going to go through very quickly some of the services that MS Connect provides. Listed there on the screen, you can see that there are 10 reasons, actually many more reasons, but there are 10 reasons on the screen there that you may want to call MS Connect. So if you're newly diagnosed, or if you're wanting information about treatment options, or managing your symptoms, or referrals for appropriate services in your area, please give MS Connect a call. Peer support. We run a peer support program here at MS, and that involves phone support or face-to-face groups that meet in various states. It could be telegroups or Facebook groups. So if you're interested in that, MS Connect is the number to call. We have an online tool which is called Get Your Act Together, and this tool helps with the common symptoms of MS. It's an interactive tool. You plug in your information and you mention your current symptoms, and it produces a personalised report. It was initially made for the ACT area, so the services that will be listed when you get your report may be relating to ACT. However, it provides a whole lot of information as well as that, so it may be very useful for you. So please give that a try if you want. Employment support services. If you'd like assistance to succeed in your work, to remain working, or if you find your symptoms are affecting you at work and you want some support there, please give MS Connect a call, and they should be able to find someone to give you some assistance. We are a registered NDIS provider, and listed there on the screen are the services that we can help you with. And once again, if you want more information, MS Connect is the number to call. If this applies to you, if you're 65 years or older, My Aged Care is available. They can provide information and help with mapping out your needs. The number there is on the screen, as well as the website address. Okay, so we're at our last slide. So a big thank you to everyone for joining us today. We'd just like to say, if you wouldn't mind staying on a few minutes after we close the webinar and complete a short survey, it'll help us improve our services in the future. A big thank you to Laura for presenting today. I found it very informative and actually very interesting, Laura. So thank you very much for presenting for us tonight. And thank you to everyone who joined us tonight. I hope you have a lovely evening, and I wish you all the best.